Thank you so much for inviting me today. So I'm going to talk about some work that we did to look at parents' perceptions of the proposal to incorporate next generation sequencing into the CF newborn screening protocol. So as has already been mentioned today, newborn screening is an efficient and effective public health strategy. It obviously contributes to lowered morbidity and mortality by identifying asymptomatic babies with serious conditions, but it can lead to uncertainty. And we've looked quite a lot at uncertainty and how we classify uncertainty, and consider, again, what's been spoken about today, that this is probably dependent on the context and the time frame that we're talking about. So what did we want to do? So we were tasked with finding out the views of a range of people on the proposed changes to the way that CF screening is done and which approach that they would prepare in order to inform the UK National Screening Committee. So just to recap for those of you who are less familiar, I'm not going to go into great detail about this, but this is the current newborn screening protocol for cystic fibrosis. And as you can see, we start off with looking at dried blood spot samples for immunoreactive trypsinogen, and then do a limited DNA panel. If babies are found to have 2 mutations following that limited DNA panel, then they're considered to have CF suspected and are referred for sweat testing. And then if they have less than 2 mutations, so if they've got 1 mutation but high IRT, initial IRT, or no mutations are detected but have a very high IRT, then they are referred to have an additional dried blood spot and further testing. The disadvantages of the current protocol include the fact that we are reporting about 200 carriers per year, and that is not the aim of the CF newborn screening protocol. In order to do that and to rule out children not having cystic fibrosis, it means that about 300 children per year will have a repeat IRT done. But this also leads to some babies being designated with CF SPID, so CF screen positive but an inconclusive diagnosis. So just to recap on what CF SPID is, so CF SPID has been defined as those babies who have screened positive at newborn screening, but when they've gone on to have a sweat chloride for diagnostic purposes, they're either found to have a normal sweat chloride, classified as less than 30 millimoles per litre, with 2 CFTR mutations, at least one of which has to have unclear phenotypic consequences, or an intermediate sweat chloride with 1 or no CFTR mutations. This has been described as an unintended consequence of CF newborn screening, and it is recognised that this causes some psychological, medical and financial impacts to the children and their families. This also depends, the number of children identified with CF SPID annually also depends on the screening programme that's used. And in the UK currently, we're seeing about 25 to 30 children per year identified with CF SPID. So what would the changes be? The changes that we were discussing with parents in this case were that instead of undertaking the 4-panel mutation analysis immediately after a positive IRT, this would be swapped with extended sequencing. And the reason for doing this would be to avoid the reporting of carriers, and I'll explain why, and also reducing the number of families who are undergoing repeat IRT testing. But there are 2 different ways that we could do this, and we wanted to find out what parental preferences were regarding which way we should be doing it. So this describes what the 2 options are, and this is based on the work of Jim Bonham's group in Sheffield, who studied a cohort of 70,000 births in England and decided how we'd actually score these variants. So the decision was made that variants of varying clinical consequence or uncertain significance received a score of 1, and any clear pathogenic variants were given a score of 2. So therefore you can see on the left-hand side that if we were to take a sensitive approach to incorporating next generation sequencing into the CF screening protocol, this would mean including all VVCCs and VUSs plus pathogenic mutations. So this would score 2 plus 1, so a score of 3. If we were to only include a specific approach, then you would only include babies who had 2 clearly pathogenic CFTR variants. So if we go for the sensitive approach, we're going to report children with a score of 3 or 4. If you go for a specific approach, you would only report children with a score of 4 only. As you can see, you would not be reporting carriers because a carrier would only receive a score of 2 or 1. So carriers would not be reported in either scenario. So to summarise this, to explain it to parents what their choices were, you can see from this that if you were to undertake a sensitive approach or a specific approach, both would lead to an opportunity to improve positive predictive value, but not identify carriers. but the differences really were between the amount of children that would be identified with CF SPID compared to the amount of children who would be identified with actual cystic fibrosis. So if we take a more sensitive approach where we include VUSs and VVCCs, then we would increase the number of children that we're seeing with CF SPID that are being identified on an annual basis from approximately 25 to about 80. So probably triple the amount of babies that are being identified with the CF SPID designation. But this would also mean that we would identify nearly all children with CF. If we do a more specific approach, then we would reduce the number of children identified with CF SPID. So currently from 25 to around 5 per annum. But on the other side of this would mean that we would miss potentially up to 10 children per annum. We currently miss about 5 to 6 children per annum of those with true CF. So we were asking parents really to balance this. Is it more valuable to increase the number of children with CF, so with CF SPID designations, so that we don't miss children with true CF, or potentially we could miss a few more children with true CF but greatly reduce the number of children with the CF SPID designation and the uncertainty that's associated with that. So what did we do? We did lots of things. It was a busy 14 months of data collection, but I'm going to focus on this bit, which is the focus groups that we did with adults with personal experience of CF. So these could be adults, so parents with children with cystic fibrosis, parents of children with a CF SPID designation, parents of children who'd received a false negative CF screening result, and also adults who'd been diagnosed with cystic fibrosis later in life, who potentially, if screening had been around, may have been designated CF SPID had that been a possibility for them when they were younger. We also spoke to 6 children with cystic fibrosis to see what their thoughts were as well. And we sent out a survey, so this was an international survey to healthcare professionals across the whole world to find out what their views would be regarding this approach to CF newborn screening. As an aside to this, we also developed a game, so kind of a serious game, which would enable families to understand the different concepts that we were talking about. So this was developed with colleagues at Coventry University. So Louise Moody, who works at Coventry University, led on this. And the idea of this game was, I don't know if any of you did play these kind of things when you were little, but and you could read a book, and depending on your decisions, you'd either turn to page X or turn to page Z, depending on where you wanted to go. And it's kind of like that. So depending on whether you take your baby for newborn screening, if you received a positive result, this is what your experience could look like. If it was negative, this is what it could look like. And we base these data on vignettes of interviews that we'd previously conducted with families who had various different outcomes from newborn screening. And the idea is that parents could use this to explore some of the different options that were available to them or may become apparent to them after newborn screening, so they could get a feel for what it would be like if you received a positive result, an unclear outcome, a false negative, a false positive, or a carrier result, so they could get a feel for what this actually would be like for real parents. And we did have limited funding, so we'd actually all appear in this as well. Needs must. So in terms of this work that we did, so the focus groups and the interviews that we conducted with adults and with children, these are sort of the main themes that came out. So the first one was around information provision. And something that really came out was that the need to make it clear from the outset, when you're explaining to people that they're going to undergo newborn screening, that they need to understand that this is not, the outcome won't be black or white. There is a continuum, and that they need to understand that they're going to fit somewhere on that continuum. But it doesn't mean they're going to get a definitive answer from the newborn screening result. And if that were explained to them at screening, parents reported that they'd feel a lot more prepared when, for instance, they were given a false positive result or a CF SPID outcome or a false negative result. They would have much better understanding of those possibilities. There was a lot of uncertainty around the CF SPID designation, and it was viewed that this could cause a lot of anxiety for parents. So one parent said it was the unknown, they were left in limbo. And another parent said, I don't think these things have to be handled really sensitive. That's the key. It's how staff are trained to speak to parents and explain what these different outcomes mean. The other idea was that you would have to support parents differently if their children had an uncertain outcome, because, and I'll talk a little bit more about this in the next slide, but they felt they didn't fit within the CF world necessarily. Their children did not have cystic fibrosis, but they weren't also considered normal. It wasn't a normal screening result. So where did they fit and where did they get support? But there was also this risk, and we know from the data that there's a risk of about 10% of these children converting to CF, and also an unknown percentage of children developing a CFTR-related disorder. So where do families go to receive support for that when they feel that they don't fit within that CF world? The good thing was that this worry associated with CF SPID was considered to diminish over time. So families were invited back for annual reviews with the CF team, and they would have repeat sweat tests done, which would demonstrate for most families that their child was fine, continued to be healthy, and they could go away and carry on with their lives. And so this was really helpful for families understanding that their child remained healthy and therefore was unaffected by the designation that they'd been given. In terms of the importance of screening, this is something that really came out strongly, was that all families who had experience of cystic fibrosis felt that you had to identify all children with cystic fibrosis as early as possible and get them started on treatment. And actually even missing one child with CF was not acceptable. And this was very different to the public dialogue that went on alongside this work. And this was because a parent with CF had said that you need to start children on these treatments very early, and a parent of a child with CF SPID said even waiting for 2 months would be too long. So potentially you'd pick up children by the age of perhaps 2 clinically if they were missed at screening, but these parents felt that even waiting a much shorter length of time would be unacceptable. Having the CF SPID designation as well, although anxiety provoking, was seen as potentially advantageous by parents. Parents felt that their concerns may not be taken seriously if they did not have this designation that they could use as a way of getting a foot in the door with clinicians. So some families spoke about the fact that they could go to their GP and get antibiotics early if their children became unwell, and they felt that was advantageous for them. There was also the argument from the healthcare professional perspective that we may be over-treating children because they also have this CF SPID designation. And then there was this balance again. So this balance I talked about between identifying someone with CF versus increasing the number of children with a CF SPID designation. It was felt that identifying a child with CF SPID was much less harmful than missing a child with true CF. And that was where the parents sort of balanced it. The other thing that parents felt quite strongly about was that we know relatively little about how to manage CF SPID. There's limited data on how children with this designation should be managed, and parents felt that the more data we therefore collect, the better scientific knowledge will be about how to actually manage these children, and definitive guidelines could be written. In terms of harms of screening, we talked a little bit about how worrisome this could be. So if you get a CF SPID designation, this can be, the uncertainty can be very worrying for parents, not knowing. Parents spoke about how these results could be very life-changing, so changing their decisions about moving, emigrating, changing jobs, not returning to work, not sending their children to nursery, were all of the things that we were hearing from parents. Even though technically these children were well, they did not have cystic fibrosis, but they had been given a CF SPID designation. Some parents spoke about feeling as if they were hypochondriacs, and again, this CF SPID designation gave them the power to go to their GP and ask for help without feeling that they were being neurotic. But other families, as I spoke about before, said that it was really confusing for them to not know where they fitted. So where could they go to for support and feel that they fitted, with some families saying that they felt like a fraud. They felt like they shouldn't be in the CF community, and it was difficult to talk to families whose children actually had CF when their children only had the CF SPID designation. So one adult that we spoke to as well talked about their experience of living with uncertainty. And I'm just going to pick out a few points here, but hopefully we can share some of this later. You can see it's far too long for me to read all of it. But this adult spoke to us about the fact that she was actually adopted. So before she was adopted, her parents asked for her to have CF screening because there was a known family history of CF in her family. So she was screened for cystic fibrosis and it came back negative. And throughout her teenage years, she experienced a lot of symptoms which would have been indicative, so digestive symptoms, respiratory symptoms. But after her pregnancy, she became very, very unwell, ended up with pneumonia and was diagnosed with bronchiectasis. And it took until that point for her to be referred to a respiratory team, who then decided to do extra tests and actually found out that this person did have a Delta F508 variant, and this person was actually diagnosed with cystic fibrosis based on their symptoms as well. But they spoke quite clearly about how it had affected their entire life all through their teenage years, how it affected their work and their family life as well. And then finally, just the cost of uncertainty. So we talked about the sort of psychosocial costs of uncertainty, but there were also, families recognise the potential monetary costs as well. So one parent said that they recognise that if we pick up many more children, so if we triple the number of children we're identifying with CF SPID, even though we have about 25 CF centres in the UK, cumulatively over 10 years, that's going to have quite a large impact on the services that we've got. But other parents recognise that when you weigh that up against parents who are going through a diagnostic odyssey because we've not identified their child with CF SPID, but then they become symptomatic or develop a CFTR-related disorder, that could also be quite expensive, and therefore it's balancing that cost between picking up additional children versus allowing families to go through a diagnostic odyssey and having various different appointments. In terms of the survey that we developed, what you can see from here is we asked clinicians whether they would prefer a sensitive on the left-hand side or a specific approach on the right-hand side. And from the browny, red and yellow colours, you can see that that's far greater in the left-hand side, indicating that clinicians would prefer a sensitive approach to newborn screening for CF. And that this clinicians also recognise a huge impact that this had on families as well. So recognise that the psychosocial impacts on families, but also the fact that this could subside over time. So this was reported by families that this had subsided over time, but also clinicians recognised that this anxiety did reduce over time. But when we looked internationally at the data and how these children were being treated, we found that a proportion of these children were being started on CFTR modulator therapies, which can cost £100,000 per child per year and may not be warranted. So the key messages that we brought home from this were that for people who have experience of cystic fibrosis, they would prefer a sensitive approach to next generation sequencing for CF screening. But that if we are going to do that, then there has to be adequate information provision about the possibility of a CF SPID designation at the time of screening, and adequate support for those parents who receive an uncertain outcome following screening. The other thing to think about is a health economic cost analysis of the actual costs of caring for children with the CF SPID designation versus those families who go through the diagnostic odyssey of receiving a diagnosis, and also further additional research to enable definitive written guidelines on how to treat children with CF SPID to avoid over-medicalisation. Thank you very much.